Good afternoon, all the delegates. Welcome back. We will start shortly. Stay tuned. Thank you.
आपले टॉप रेकॉर्ड पण दिलेत का? Welcome all delegates. We will start in another 5 to 5 minutes. We are waiting for some more participants to join the meeting. Welcome all. Welcome all. Hello. Mic check. Hello. 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 Mic check. Welcome all. After a lunch break, we again join together to have a second session of Telegao Dabade IMA 2025th conference. In second session, we have with us the speaker, Dr. Mubarak Mohammad Khan. He is consultant and director at Sushrut ENT Hospital and Dr. Khan's Research Center at Telegao Dabade, Pune, India. Has worked as an associate professor at Maimar Medical College. Dr. Mubarak Khan is author of 3 books, holds 25 publications in prestigious laryngoscope, JLO, AJOHNS, IJOHNS journals. He is a founder, director, and president of Dr. Khan's Creation and holds 2 patents for Just Attach and Endohold. He holds 4 IPR in design and trademarks. He has been invited for 10 different countries as a faculty and for his pioneer work on two-handed endoscopic ear surgery, cartilage tympanoplasty. He has been invited as an operating guest faculty for 39 times till date. He regularly holds masterclass to teach his innovations and new techniques to EES. He has been invited as guest faculty to 81 prestigious conferences, medical schools, universities to deliver keynotes, lectures on his many techniques and innovation. Till date, through his 9 master classes in Telegao, Dabade, Pune, he has trained 100 plus ENT surgeons from India and abroad. He is keenly interested in research. Dr. Khan has intense passion for endoscopic ear surgery, instrument design, cholesteatoma surgery, and cartilage tympanoplasty. Till now, he has developed Just Attach, Endohold, Slice It, Endoplay, and he has applied for 4 more IPR government patents in Indian government. He is a reviewer of many prestigious international otolaryngoscopy journals and also works as an editorial board member of otolaryngoscopy journals. He has as an extracurricular activity, he nurtures his hobbies in the form of writing short Hindi poems and ignites mind with his positive philosophical thoughts. Also, I know him as a great singer who frequently puts his singing bites on our group. So, with this short introduction, I request Dr. Mubarak Khan to take over the stage and present his topic on OPD practice changing in COVID-19. So let us hear what the COVID-19 has brought us, what changes it has brought us in the OPD practice. So I request Dr. Mubarak Khan to on the stage and present his topic. Mic is on.
Yes, good afternoon, everyone. First of all, don't forget this. Now I will be taking it out, but don't forget the mask because the corona has not still ended. So, once again, I really thank to the team IMA, Dr. Gopal Ghare sir, then Dr. Amit Kulkarni, Dr. Narkhede, and Anis Bhatt for the nice introduction. Few things about boss. My boss, that is late Professor Dilip Bhoge sir. I still remember when 20 years back I started my practice. I never known about this Talegaon. And only one prominent hospital at that time on the in Talegaon station was Pratap Memorial Hospital. So I just gone and meet sir. Sir, I am Mubarak Khan, and I'm thinking I have not joined at Myanmar Medical College at that time too. And 20 years back, the last stop was Pratap Memorial Hospital. Beyond that, there was nothing. Now you can't identify the Talegaon station. So he welcomed me. He looked at me. Oh, young man, immediately start. We need young people, and I can see a good future of you in Talegaon. And he has witnessed me, and he inculcated the confidence in me. And he was the first person to offer me a tonsillectomy. Believe me, a new man who never known Talegaon Dabade. It was always there on that highway when I used to go to Mumbai, and I never destined to be in Talegaon. And this man, and I was first, he offered me the tonsillectomy in his own hospital. So, idea to tell about is that giving a confidence to the young people, inculcating that confidence in the new people, and I have known him for the last 20 years. I am being a part of Myanmar Medical College, and I still remember whenever I used to come in the morning, so I used to search Sir's car because it was typical destination. It was parked in front of the OPD. Oh, sir is there. So let's go for the round. Then we had a cup of tea, and then we used to chat. I mean, so many memories with this man. So I called him a boss, and he was a part of our Marvel imaging also as a director. So every month we used to meet, and during this Corona only we couldn't meet due to the social distancing and all. But once again, I give a great tribute to boss Bhoge sir, and I pray to rest his soul in a peace. And I will start my lecture today. So, what's the safety practice guidelines in COVID-19? As if now we are seeing that the COVID is over. No, COVID is going to stay there. Still, we are walking into the no man's land. We don't know still about much about the Corona, SARS-CoV-2 or the COVID-19. What we can achieve is to have safe practices. The healthcare workers and the doctors are at the forefront who bears a maximum risk to get exposed to the SARS-CoV-2. So I will be talking about what necessary practice changes you need to do in your practice. We never close our practice. As Dr. Bhondre sir has told, during the whole Corona, only 2 days we have kept our practice closed. Otherwise, myself, Dr. Sapna Parab, we never close our practice. But we researched, we reread, we reviewed, because a lot of things are there. The great people has done a lot of work in the literature. We gone back to the literature, searched for so many things, and we designed our own guidelines to practice during the Corona. And believe me, in the last 6 months since the lockdown has been started, we never closed the OPD, and around now 9,000 plus patients we are seen till now with our this practice. And fortunately, call it as God's grace or give some credit to these practice guidelines, we are still there. And I think these are going to be there, and one must follow these practices because all doctors are at risk for this Corona, not for the Corona. Corona will go, COVID will go. No, it is not going to go because no pandemic goes, because the influenza is still there, swine flu is still there. This virus will get mutated, another virus will come. With these myriads of viruses, we can't avoid. Vaccines, don't know. Many vaccines has come, it has failed. So what we can do, how to do a safe practice, each and every doctor. Although I will be talking much about the otolaryngological practice, but these are similar to for the all practitioners. So let's go for that. And Anis has introduced it already. How can I shift this? Because you see this Zoom. How to shift? Yeah, I can't read this here. Okay. Yes, perfect. Yeah. So first disclaimer. These are our practice-based guidelines developed during the Corona pandemic. Call it our experience. Few of our work is published in index journals like American journals, JAMA, and some comments in the Science. and rest is our personal experience. We don't claim any cure of corona with our practice guidelines. Everything must be interpreted with your expertise and the experience. Being a part of our company, Dr. Khan's creation, my views may be little bit commercial, but I don't claim for any cure of the corona. So, little bit about COVID. Now you know everything in the world of social media. The knowledge spreads like anything. Daily you have read much about this. Just few lines about it. The oropharynx and the nasopharynx are the target sites. Believe me, saliva has the high viral load, that is 1.2 into 10 raised to 8 infective copies per ml. So just imagine if I am speaking now, this saliva is coming into the environment, and believe me, with per ml, 10 raised to 8 viruses are coming into the air. So just imagine in your OPD, 100 patients. I know the people who are seeing the 100 patients. Even we are seeing daily 40, 50 patients. So imagine the viral load in that environment. As an otorhinolaryngologist, we closely work in this area. There is a significant risk of exposure during the routine office-based examinations of ear, nose, throat, and many endoscopic procedures. And similarly, the pediatricians, because they go very close to that. Even the physicians, they go very close to the patient. And imagine the viral load in the intensive care unit. You all have worked into the COVID area. So just imagine, I will be talking about how to reduce all this viral load in this environment. So even few microliters of saliva contamination of surfaces or the instruments may carry many thousands of infectious viral particles, and many healthcare workers and our many colleagues has succumbed to the corona due to this, in spite of using the PPE and so many other things. So though asymptomatic, those are the total different kind of people, because asymptomatic carriers are the most dangerous, because every patient who is coming to your OPD, consider it's a corona positive unless proved otherwise. So that should be the dictum in the future. So the viral shedding initial phase of COVID-19 is highly infectious. We believe not a single thing, that is our personal opinion, not a single thing can take care of the corona or what is called the COVID-19. So we formulated our guidelines based on our experience. You know the PUBG, it is banned now, and again it might start. One of the most famous games. So to remember, so I made it PUBG. PUBG has gone. So remember now the PUBG. So what is that PUBG? P is an personal protective equipment. You know that. You need to wear PPE in day-to-day OPD practice. Let corona be there or not there. Whenever you will be touching the patient, you need to have the personal protective equipment. So that is for creating the strong barriers between you and the virus and other borne air diseases. Why you are thinking about the corona? Think of the even the Mycobacterium tuberculosis. You think of the other microbes who are there in the environment. So you are going to take care of that. And you are exposed as a doctor, me, and you are too much exposed, because every patient is coming to you and going. So you are exposed too much. So what is this PPE? Using the simple mask, 3-ply mask, or N95. In our practice, we have just used the N95 mask and rest gown. Simple surgical gown. What we are using for the surgery, we are using that, and we are daily autoclaving those gowns. Not ourselves, our whole staff wears that. Gloves, then cap, face shields, and the sanitizers. This I will talk about ultraviolet light. Why you need an ultra when you are using so much of PPE, but you have not thought about the what is there which is resting on the surfaces. What is there in your air? When those 100 patients are sitting or the 10 patients are sitting into the waiting room, what is the status of that? When you are checking the patient in 10 by 10 room of your OPD, what about that environment? How many viruses are there through the breath, through the spitting, through the cough, through the talking? So how to take care of that? Either you can use the chemical disinfectant or
Gopal Ghare asking sir login झाले
and other
ठेव लागेल मला बोलायला
sterilization.
आवाज येत नाही येतोय
I'm not talking about UVC as a new thing. It is there. It has been invented long back, as 100 years back, but it's not been projected for many other things. It has been used for the microbiologist. It has been used for so many other people by that. So using the UVC germicidal light, or chemical disinfection of environmental air surrounding you. If you're using the chemical disinfectant, so you can imagine it has got a corrosive effect, that is sodium hypochlorite and all, so many other problems, and simple UVC doesn't carry that much of weightage, but other precautions has to be taken for the UVC. We will talk about that. Betadine, that is an povidone iodine. That is our research. We have not done some great thing about it. It was there lying in the literature. We just taken it out and we implemented from the first day of our practice. So 0.5%. Povidone iodine is there. 2% is there. Dentists are using that. But we wanted something which can be used for the gargle as well as putting into the nose, because these are the main two sources where the SARS-CoV-2 stay. So 0.5% povidone iodine gargles and the nose drops for all patients. Believe me, we are doing it for last 6 months and we will be continuing till the end of our practice. Nothing harm, no harm. Why? If you are getting a 2 hours of risk-free period, and it is proved, and now after our publication, lot many things has been proved in JAMA and all. They are directly exposed to the SARS-CoV-2 and kill the SARS-CoV-2 with the 0.5%. So 0.5% povidone iodine gargles and the nose drops for all patients before examination, and the healthcare workers who are actually tackling them, who are busy treating patients irrespective of COVID status. So just do it and then examine. Ventilation. This is the new concept we are developing, because the ventilation is all that is important in your environment. So the reverse ventilation with the filter, it's nothing but as an air purifier. Air purifiers are too costly. You can just make it by yourself. Okay, so how? We will just see that. And I will talk about the betadine in little bit detail in another small presentation. So when it started, you go back in the March when the lockdown started, there were no masks. We were fighting. Remember our group chat. We were just searching for this. Where is this? 300 rupees, 500 rupees, not even the another pass. And then there was a face shield. There was no face shield because it was not prepared. It was never was there. We never thought of that, because the face shield was supposed to be used by some other mine workers and all, or who are working as a welder and all, for all these things. So we designed ourselves because we wanted the protection. Nothing but simple OHP sheets. And that has been published, and now this has been cited too much. With a simple OHP, that is an overhead projector sheet, we created a face shield, and our whole staff, still we are using the same thing. Believe me, it can be sterilized very well with the sodium hypochlorite, and you can go on using it. Simple. How much it costs? 2 rupees. Okay. So how we are doing the ENT consultation, and you consider the same other consultations with gloves, double mask, either surgical 3-ply mask or N95 plus N95, and use the face shield. Examination, at least for the otorhinolaryngologist, we use the endoscope. So to keep that distance with the endoscope, we are using it as an exoscope, and we are seeing on the monitor. So we are not going directly. Otherwise, we are using the tongue repressors. No, just we are using the endoscope as an exoscope. We are seeing everything on the screen. Because the telemedicine and all, it's not possible for our patients, you know that. And or we use the long endoscopes like a uteroscope of 30 centimeter. For each examination, we use 2 endoscope, and for the sterilization, we use a simple 2% activated glutaldehyde. So the bottle is there. After examination, just put it in that, sterilize. Till that time, the another endoscope is there. You can just go for that. Okay. Even this simple endoscopic examination, we can be used by all dentists and for many other practitioners, if at all they want to see, so by exoscopic. So like this, we just put an endoscope and look at the monitor. So that we are avoiding the direct contact with the patients, and all the people or the healthcare worker are with PPE. So what's the safety consideration? How to do that? How to use those face shields? Because you are using the face shields. But imagine I am sitting, the COVID positive asymptomatic patient is sitting in front of me. He is talking, is actually spitting. So it is coming and falling on that your face shield or whatever it is, OHP shield. How to sterilize that? Because you are going to use it again, or somebody is using, because that corona spreads with your contact too. So what's this is also published in that, and very well cited. And believe me, the Brazil implemented this simple OHP thing, because you know the Brazil suffered a lot, like, yeah, and they wrote me a special letter that we don't have this, and by reading your simple paper, they just OHP 1 rupee. So you can still use this for the things, and it's very simple to sterilize it, or you can use it as a disposable. That's all. 1 rupees, 2 rupees. It's not a big thing. So it should be snug fitting. What it should be? It's not like a marketing. Whatever they are giving this nice fancy face shields and all. No, it should be snugly fitting around the head without any gaps between the forehead and the shield. The ready-made plastic bands are not tight fitting and may fall off with the repeated use. Use of sponge in between the forehead and the face shield gives good comfort. But believe me, such face shields should be used as a disposable because the sterilization is incomplete with that sponge and all. Disposable, reusable, absolutely no problem. In case of disposable face shield, remove to be done with utmost care and dispose it properly, means with the clothes. Reusable face shields, utmost care to be taken while removing the shield after use and then sterilize it before reuse. Reusable face shields must be free from any sponges or the sticking material or a stapler pin to achieve good sterilization. Minimum 5 reusable face shields must be kept in reserve to use it alternately, because when you are using other will be getting sterilized. Quality, what material should be used? It's an OSP, but not 50 micron and all. It needs to have that good thickness. So at least 150 to 200 micron thickness OHP sheets, because that repeated sterilization will avoid and also it will avoid the crimping. How to handle that? Never touch the front side of face shield. With gloved hands, remove the face shields from behind by untying the ribbon knot. Dispose along with the gloves. Methods of sterilization, simple. The sodium hypochlorite is very effective thing and very cheap material which is available for your killing not only the corona, for all viruses and almost all microbes. So the 1% sodium hypochlorite solution for minimum 10 minutes. Drying in sunlight and cleaning with the sanitizers with glove hands. That's another method, but you have to use the gloves. 2% glutaraldehyde for 10 minutes. Also, you can use, best way is to ETO. It's a prudent to avoid all supplementary materials like sponge, stapler pins, sticking materials, adhesive, and any other fancy material for aesthetic appeal for the face shields. How to do for the OPD? What changes we have done in OPD setup? For the staff factors, OPD complexes must be cleaned with the sodium hypochlorite. After every OPD, our staff completely sterilize the whole of the area with the sodium hypochlorite, and all OPDs and OTs and all, now we use the ultraviolet light. All tables, chairs, computer, etc. should be wiped up with the sodium hypochlorite solutions. All must be in a gown, face mask, face shields and gloves. Appointments of the patient must be spaced. So only there should not be any crowding in the OPD. And even the money collection will be the gloves. Believe me that money carries out. It's not risk for you, it's a risk for who is collecting the money. Because that is the one thing which is handled by everyone. It's a proved research, even that mycobacterium spreading through the nodes. So you can just imagine, and you can't sterilize. Believe me, you can't sterilize your nodes, put in some sodium hypochlorite and sterilize it. Okay, you can keep it on the ultraviolet light, but how many times you will keep that? So the simple thing is collect it with the gloves and use UVC for that. Don't forget this. This is going to stay for the 100 years. So that's why sometimes I thanks to the Jain Muni, because they even don't allow. They are using it for the 1,000 years. Why? Because they don't want to kill any life, not even the bacteria and the viruses. So they are using the mask, and now we must make use of this mask forever. Let whatever corona be there, not here. Even for whenever you are going to the, now it's unlocking, wherever you are going into the multiplexes, where you are going into the crowded places, when you are traveling, this must be the norm. A simple mask can, because it's again nothing but creating a barrier for yourself and between the virus. What patient factors? Compulsorily, we have made one big board. Without mask, nobody should enter, and you should not take any patient into the OPD. So all with the mask, and even not more than one relative along with the patient, and he should be also wearing the mask. Only patient is taken inside during the consultation room. Patient doesn't touch the tables at all, because it was an active, because we were continuing the OPD during that active time. Little bit now it's slowing, but keep it the norms. Miscellaneously, doors kept open when the so that no one touches the knobs and door every time the patient is coming and all. Spraying of sodium hypochlorite solution at the end of the OPD. Fumigation of OPD. Previously, we were using, when I was not prepared for the UVC, we are doing the fumigation and then cleaning and mopping of floors and tables with the sodium hypochlorite. All emergency at that time also we done emergency because ENT is having a, although it's a small thing, but small foreign bodies, parents gets very panicky, so we can't avoid. So and those foreign bodies are either in the nose only, where the SARS-CoV-2 is staying. So foreign body removal, we all done that, but with all the same precautions. And also now we are doing the same thing. So a little bit about ultraviolet light sterilization, because I thought little bit, myself and Dr. Sapna Parab, we read a lot and we thought that we are taking all these things. And even my friends succumbed to the SARS-CoV-2, and that impacted me. And later on, the boss succumbed to this. They are using the proper PPE. They are using so many things. Still, they are succumbing. What's the reason? Then we thought, I came to know that because at that time the whole world was rattled. Everyone was just in search of that. What will happen to that? So we thought that how to reduce the viral load. I'm not claiming that I'm killing the virus in the environment, but how we can reduce the viral load in that environment, because the doctors and the healthcare workers are at the receiving end. So we came across with the ultraviolet light. The CDC is using for the so many sterilizing for the so many bacteria and all. Only why they have not made it public, because it will be used irrationally, because its precaution is needed. It has got some problem because you can't expose it with the directly to the eyes and then expose to the skin, because it has got that problem. But with the proper precautions, you can use it to kill, to reduce the viral load in the environment. So ultraviolet C light, that is ultraviolet A, B, and C. This ultraviolet is divided into three. So ultraviolet C, it's called the germicidal light, and which is having the wavelength of 250 nanometer, is called is basically known to kill many bacteria, viruses, and fungi. And our company, and we have one company, so we developed those. We contacted Philips at that time. Also, those were not there. So we contacted. We asked that he give some tubes and all. So they made it available, and now we have made that particular lamps available for the sterilization to achieve that 90%, because it's not called 99.9. It's called D90 for reducing the corona or any microbe to the up to 90% level. So UVC dosage is very important. By just putting some blue light in the environment, you can't be assured that the corona or any microbe is killed. The dosage is very important. Here I will just talk about, now I am working on that UVC not for the corona. We are using it for the all microbes, fungus, your bacteria, all viruses, and even the prion. Only the dosage changes. But corona, it is killed with only 67 joules per meter square. And if you look at the UVC light, those talk about this UVC light is giving you this much of delivery, but that talks about the microwatt per square centimeter. So how to convert that? Just joule should be multiplied by the 100. So only dosage which is needed for the corona to kill is 6,700 microwatt per square centimeter per second. Okay, so how we will achieve that? So if you are having the tube, little bit it's technical, but that is very important. Otherwise you can't just put one tube light and be assured that the corona is that. So the dosage is what is the output of ultraviolet light and how much time you expose it. So if suppose I am taking a UVC lamp of 36 watt. 36 watt means it is delivering the 36 joules. That's actually interpretation, but no, it actually creating or delivering the ultraviolet light of only 100 microwatt per square centimeter. So if it is 100 microwatt per square centimeter, to achieve 6,700, how much? So you have to just expose that for that time. That's simple. So the next time when you will go for the ultraviolet light, just think. So if at all you want, if I am in this area, this area must be around some 2,000 square feet. So if I want to sterilize this whole thing and with instantly, because the lectures are going on, now the next lecture is there and you want to instantly do it. If you want only in 5 seconds, it must be get sterilized. So I will use 10 36 watt tubes, and then I'll put it 5 seconds, it will get sterilized. So like that it goes. So that's simply. So coming back to the very simplistic form, ultraviolet light works and you must give credit for that. So depending upon if the tube is of just 16 watt, it will need 5 minutes. So this is calculated like that. Okay, if it is in 36 watt, only 2 minutes for this area. And if it is 72 watts, only 1 minute. So if you will increase the tubes, it will come into the second. So within 5 seconds, you can go for that. So that's about the ultraviolet light. Definitely go for that, because you are going to practice for the at least for the next 40 years. So, and this is really one thing which has changed our practice, that is povidone iodine. Povidone iodine is not a new thing. It is it's already there. It was there. It's a 100-year-old drug, and povidone iodine came for the last 50 years, and it is known to be bactericidal, fungicidal, virucidal. But now, if at all you want to sterilize the throat and the nose, you can't put a 2% povidone iodine into the nose, because that burns all your nasal mucosa. Okay. If at all you want to do the povidone gargles 3 times, 4 times, 5 times, it might change the taste with your percentage, that is 2%. So we just searched out whether by reducing the concentration of this povidone iodine, the same thing can be achieved. And wow, there the person who has done the work. Oh, 0.23% kills SARS-CoV-1. He has published that in that SARS-CoV-1 that is called MERS. Oh, if it has yes, speculated about that. So I thought, what's the harm by using this simple thing? Make it as compulsory to the patient. You have to gargle, you have to put the nose drop, and then come to me, because you get it kills the SARS-CoV-2 in a 30 seconds, and you get a 2 hours of risk-free period. So why not to use it? So we prepare that, and this is the way daily for the last 6 months we are doing. Whenever the patient comes, now we have put a dispenser also, the automatic dispenser with a disposable gear. You just put it, just 15 ml comes through that, take it, and then gargle it, and then our staff it puts into the nose, and well accepted, 0.5%, and that has also been now a well cited article which we have published in the American Journal. So just think of this, do it, very simple for yourself, healthcare worker, very important, who are working in the intensive care, very important, physicians, pediatricians, very important. So, okay, so whenever the contact of the patient is coming, what's the harm in doing the gargle? And that has been known even for during the Ayurveda, just to gargle and do the things. So just go for that. And we started the surgery. The same thing we extended. For povidone iodine is used again for the irrigations. That is in 5%, 10%. That's a known thing. I thought that why not to use a 0.% when this is be there. So now for all hysterectomies and for all the surgeries, we just use an irrigation. That paper 2 years been published. That's 0.5%. In a normal saline, prepare the 0.5%. I'll tell you how to prepare that. 0.5%, make that solution, and we use it for the coblation tonsillectomy. We use for the drilling and all. So saving that what you can call a generation of the aerosols. Last thing, this we are working, and we are working from the first day. Still, we have to prove it scientifically, but logically. When you are using the mask, you are taking the air, getting filter, and going out. So why not to take the environmental air sucked into something, filter it out, and let that air come into the environment. So that was an idea. So that's called the reverse ventilation. If I go a little bit longer time, please tell me, I will stop. Okay. So because this is an actually 1.5 hour of so the mode of transmission of COVID-19 is through the droplet infection and aerosols. To deal with the infection in the outpatient office setup, we need to have not only protective gears and equipment, but also need some device which will mechanically remove the virus and reduce the potential risk of exposure. So we propose and put forward the concept and design of a reverse fan. Reverse fan is nothing but it looks good, nice word. Simple exhaust fan, which is daily working in your bathroom. Okay, so that's called a reverse fan. But this reverse fan, kya badhiya lagta hai. So that's a reverse fan with inbuilt filter. What is inbuilt filter? There's nothing called inbuilt filter. 3-ply mask. You are using it as a filter. You are putting it. So my air will become. At present, we are sending that air from our bathroom to the outside. Baki ka dusra le lo. Usko filter laga do, bhai. The air will come. Whatever it will get filter. Whether it will filter, come on, I'm not telling that 90% is filter. No, 30% filter, but whatever is filter, it's get filter and it's coming out. So propelled air thus expelled will not be biohazard to the other present in the clinic. And The filters used is disposable and has to be replaced daily. That's all. 3-ply mask we are using. This can be about 2 to 3 such reverse filters in consulting room. तुम अगर हमारा consulting room देखोगे तो Dr. Sapna or sometimes me are sitting with those filters only in and around that. You must have seen the Anis. So that's about the simple concept. I will leave about that. If at all you want, you are technically, scientifically, you want something, 99%, we want 99.99% filtration, use HEPA. HEPA is too costly. But still it is not sure that, your will is completely filtering. But simple 3-ply mask with your exhaust fan. How much it costs? Exhaust fan, 1,000 rupees. This. So just go for that. That's a concept. So this was the thing which we submitted when I in March I designed this exhaust fan. Front में सिर्फ sponge लगा दिया, पीछे exhaust fan, उसके पीछे 3-ply mask. That's all. So first filter is to filter it out your dust and all. जो कुछ air जाता है 3-ply mask से filter होके बाहर आ जाता है. That's all. That's a concept. This we submitted to BMJ Innovations and still it is there. So let's see. So that's about here. I will just go for it. So this is how it's now we wanted to make it that. So the patient is sitting, says Dr. Sapna, and these are the 2 filters. So when patient is sitting here, because whenever a patient opens the mouth, whatever things are coming, this gets sucked here. I'm not saying 100% it's sucked because it depends upon the power of that reverse fan. But whatever is there, I am making air that's droplet reducing to reach to that consultant. That simple thing. So यहाँ एक है और पीछे बहुत बड़ा है. Otherwise, what you can do in your OPD, put like in bathroom, put in 2-3 big exhaust fans. Okay, that's all, which will be circulating the air. So that's an idea about the filtration. So function uses I will not go because this is the main function in a corona and not for the corona, for any other airborne contagion. This will be the best thing. So sometimes I thanks to Corona also because that gave me opportunity to innovate so many things for myself and Dr. Sapna. So the solutions are always very simple. It's around, easy and in and around us. We have to just keep our mind open to imagine and to repurpose them. I have not done such some great things and all. I have just repurposed. Iodine was there, just repurposed. Reverse fan filter is there. When reverse fan is there, I made it a filter. Otherwise, your air purifier, you must have seen 10,000, 15,000. And if you want to fit it into your walls and all, simple thing, you can just go ahead for that. So think about that. And don't forget, PUBG nahi, PUBV. PPE, ultraviolet light, betadine. Okay, I'm not a promoter of betadine because betadine actually a commercial name. It's a povidone iodine. And V, ventilation. That is reverse ventilation. Thank you. So if I have 5 minutes, just I will talk about betadine, how to prepare. That's one slide only. Okay.
Sir, please start screen share again.
Yeah. These technical glitches I have not still mastered. So we have minimized that. Okay. This one. No, this on this one. Yes. Although now 0.5% is commercially available, you must be remembering when we wanted it, it was not there, and so we prepared ourselves, myself, Dr. Sapna, and then my staff. I taught them how to make it. It's a very simple thing, and still we are making that because daily we need 5 liters of povidone iodine for our patients because we offer them to do that, and then after that we take. So how to make that? Many times I have shared on the many social media platforms, and then we have published also. So I will just directly go, skipping all these things, how to make it. So just one thing, because always you should give credit who has actually invented all these things. Iodine has been recognized as an effective bactericidal since 1800. Okay, and povidone iodine, that is PVPI, which you routinely use, is a water-soluble polymer, and that is polyvinyl pyrrolidine was discovered in 1955 in Philadelphia by H.A. Shelansky and William V. Shelansky, for whom the patent has been offered, and that was changed the practice after that. And you know that still we are using the povidone iodine over, and without that surgical practice is impossible. So it's less toxic than the tincture iodine. Onset of antimicrobial action of PVPI starts when the free iodine is released from the polymer, and that free iodine is very important to kill any microbe. So the free form of iodine penetrates microbes, disrupting the proteins and oxidizing the nucleic acid structures, resulting ultimately in a microbial death. Broad spectrum antiseptic with activity against bacteria, fungi, and viruses. Previously used in both intranasal preparations against MRSA as well as for the oral preparation in vitro studies for the SARS-CoV, MERS-CoV, H1N1. Believe me, it's there. Japan is the only one country, because this is how we collected the data where it is. Japan is using povidone iodine, which is a very diluted form, for the H1N1, for influenza, for all the influenza pandemic. They are using the gargles and they have the nasal spray. Simple things to avoid the so the higher virucidal activity than the chlorhexidine. Chlorhexidine has got a lot of problem because you can't put it into the nose. Benzalkonium chloride and SARS-CoV-2 is highly homologous with SARS-CoV, and now this is all written 4 or 5 months back, but now it has been proved that how the 0.5% kills the SARS-CoV-2 from the Stanford to the University of Pittsburgh. They have done directly by putting SARS-CoV-2 and putting a 0.5% at the, and the clinical trial is now going on. The big clinical trial is going on in America after this publication. So this is commercial products which is available in 2.5%, 5%, 7.5%, and 10%. Need not to worry about this. Just you need to know the formula, how much to put it into, and you can prepare yourself. So again, I call this man as an boss because he directed me to create 0.5%. So the Eggers et al. Showed the activity of 1% PVPI against the MERS-CoV. Okay, when used for the 30 seconds under the dirty conditions, viral activity reduced up to 99%. Second study by Eggers et al. Showed that he reduced it to so much level. Okay, what is the smallest level at which these all viruses can be killed? So it was 0.23%. Now the simple question comes, if the Egger is saying 0.23, why you want 0.5? Simple. What logic myself and Sapna give me? Because when you are putting into the mouth, saliva is there. Because it's again getting diluted. So double it. So even if it got diluted, you will get a 0.23%. So that it will be killing the things. So that's a simple idea. And 0.23 throat spray is there in the Japan. Okay, and that is called Nodo Fresh, and it is available for since 20 years. But we never known this. They are using, and we just repurpose it. So I will avoid all these things. Just directly go how to prepare the 0.5% PVPI. And this paper we published because the idea was given by Mandar Pranspe that कि भाई हम ऑप्थेल में इस्तेमाल करते हैं, हम बहुत सारा नाक में डालते हैं वो ये करने के लिए, और आंख में भी डालते हैं, कुछ नहीं होता है. तो उसने सपना को भेज दिया कि देखो तुम्हारे पास, क्योंकि या मेरे पास भी सामने आके बैठते हैं करके कैसा करने वाला देखना पेशेंट. So he just gave us a thought, and then Sapna started reading. चलो निकल, तो बोला है कुछ करेंगे, and then we read the many things and we repurposed and we prepared and then we published the things. So publication is with myself, Sapna Parab and Mandar Pranspe. So how to prepare? Just a final slide. I will not go much more detail. If you want to create a 0.5% from the 10% solution which is available, okay, which you use for the surgery, very cheap, 100 rupees bottle, 500 ml or betadine you come and you can prepare a lot. So how much you have to use? Only 1 ml of 10% povidone iodine in 20 ml of sterile or your purified water. That becomes a 0.5%. Okay. So similarly, if you want to make 1000 ml, just multiply it. That much is so 200 ml. If you want, it becomes a 10 ml. So if you want to make as an 1000, it becomes a 25 ml. So for the 10%, if you have a 5% solution, just go on doubling or reducing the water. So 1 ml of PVPI in 10 ml of sterile or purified water. If it's on 7.5%, Then use 1 ml of PVPI in 15 ml of sterile water. And if you have got a 2.5% of povidone iodine, not a gargle, povidone iodine, okay? So use 1 ml in 5% of sterile water. So how we do is simple. Whenever the patient comes to our OPD, 4 or 5 drops of this 0.5% we instill into the nose for 10 minutes prior to the examination. And for the endoscopic examination, we are doing the nasal packing. So we now do the nasal packing with the betadine, 0.5% betadine, and 10 ml as a mouthwash for 30 seconds, and then gently it is gargled or held at the back of the throat for another 30 seconds. So that's our procedure. You have seen that how it has been done, and we are doing it not for the OPD patients, for the all operative patients. We ask the patient to do it for the before 4 days. You start all these things, and wherever the anesthetist take inside the OT, he just go for the gargle, put a nasal drop, let it be tonsillectomy, let it be any surgery, and then he comes inside. So that is the simple thing. Or you can put a nasal packing, because nasal packing is a mandatory for our ENT surgeon. So previously we were using 4%, so we are adding now 0.5% little bit, and we are putting the nasal pack. Do it, and do it. Very important, because the corona is going to last, and this is the data, and this data is being published now. It's in publication 9,952, because we keep an all data. This many patients who has visited the Dr. Khan's clinic has done the gargles. Out of these 10-15 patients refuse, we said namaskar, dusre doctor ko dikha, because we don't know what is the status. We never done, and fortunately our patient has not succumbed. I don't claim anything, but not succumbed to the anything. Could be this reason, or maybe Lord must be helping us. But as a scientific man, we have to talk about the data, and we are now analyzing the data. And at that time, it was 5,000 rupees RT-PCR. Now I can go, because the government has made 800 rupees. So now we are doing the research. So I will come up with the another research. So thank you. I will not go for the discussions. So we have discussed a lot. Don't forget, simple, 2 rupees. 3-ply mask, 0.5% betadine, little bit costly, ultraviolet light, because that will save you a lot of furniture if you are using the sodium hypochlorite. Okay, so remember, not PUBG, PUBV, PPE, ultraviolet light, betadine, not commercial, povidone iodine, and ventilation. That's called the reverse. Thank you once again for the great team, and I appreciate the great work done by Dr. Gopal Ghare, Dr. Amit Kulkarni, and the present treasurer Narkit sir, and my boss, who has started the TIMACON. On this ground, one thing I liked about Dr. Pate sir, start the oration on the name of this man, and right now from this dais, I announce 11,000 rupees to IMA to start the oration for the Dr. Bhoge sirs on name of it. Okay, so in TIMACON, the thing should come, Dr. Dilip Bhoge's oration, because in our all conferences there are there Tepan sir's oration. So please start it, and try to make even in the state branches that his oration will be created, and that will be our great tribute to him. So thanks once again, and I want to see, this is the 5th. There should be 10 more. Please. So keep a good work. Thank you very much once again.
I just had a question regarding putting the iodine drops into the nose.
Yes.
So who is putting that? Patient himself or
No, our staff. One staff is appointed for that.
So she will be going very near to the patient.
Yes, but she is using. She is in PP. She is in PPE, and then she is putting the drops. We are daily seeing the patient in front of us, so they are in front of us. So, but PPE we are using, and gargles they themselves do, because the dispenser is there. Still, see, there is a lot of logistic problem. Now the company has come with a 0.5% gargles in the market. We are behind them. They prepare simple nasal gate so that it will be. But they go for the all commercial things and all. Hope say one day it will come. Okay, like a Nodo Fresh in Japan, so that my patient will be doing themselves. And
Regarding the UV light, you keep it in the chamber.
no, not chamber. This is for the environmental sterilization. These are the big tubes. We use it for the OPD for the operation theater. So these are the big tubes. We keep it in an open so that the whole surface is exposed and the light falls on the whole of the objects in the room.
What happens to the undersurface of the object which will get with that?
Yes, that's a very good question. For the undersurface, you have to change the angle. That's why the new tubes which we have created, it has got changing heights so that it will reach everywhere. Okay, so that's an idea. So this is a little bit of things which needs to modify, and we are modifying that. Yes.
Thank you very much, sir, for your simple and easy guidelines for prevention of this COVID. I personally thank you because because of your recommendations, I was using this code in identity.
Oh, nice.
And because of scarcity of physicians, we had to say 3-4 COVID centers, and I used it. And I'm happy to share with you that I'm one of the physician in our
Only physician.
area.
Only physician.
Officially COVID negative.
Yes. After doing a lot of COVID work.
After doing so many
Yes.
COVID work, I'm really thankful to
That's
you.
all.
And I will urge all the audience to use the PPE kit or this face mask, and if code in iodine, if you are seeing the patients in OPD, I don't have any experience with this UV light and ventilation, but at least our consulting room should be properly ventilated. I have one question. You said that the person who is collecting money should use the gloves. Are there any evidences? That the currency notes spread the COVID virus?
Yes, that's a really good question. I tried searching it a lot, but at present there is no study. There are the studies that cannot spreads mycobacterium. That's a proved thing because these are handled by so many of people. That's why the bank persons I know. Whenever the person comes from the bank, I first ask where you are going. Bank? Okay, you're having the allergy. Definitely, that's one thing. This is due to the notes, and many other microbial infections are there. But for the corona, during this last 6 months, we just want, but we not come across with that way. But simple thing to do, if the notes are there, we can do a simple study, take a swab and just send it and check it out whether it is there. That's the thing.
Aditya, kindly give the felicitations. I request chairpersons Dr. Santosh Borkar sir and Yuvraj Bhatt sir to chair for next session also. So after a lot of innovative talk, we are heading towards imaging, which was a cornerstone in diagnosing COVID. Here we have our eminent speaker, Here we have our eminent speaker who is already online from 2 o'clock, Dr. Santosh Sabnis. He is practicing radiologist, MBBS MD radio. He is practicing radiologist in Talegaon, Dabade from last more than 20 years and has immense knowledge in imaging, and also he has done his work during the COVID persistently without a fail of a single day. So I request Dr. Santosh Sabnis sir to put some light on imaging in COVID-19.
Yeah. Can you hear me?
Yeah, we can.
Yes, sir.
I'll just share my screen. Yeah, good evening, seniors and your friends. And it is indeed on a somber note that we are arranging this CME, remembering Dr. Boge sir. Like all of us, I'm sure myself, rest of the team, everybody is missing Boge sir. It is really unbelievable to think that sir is not with us anymore, guiding us, helping being with us in all small as well as large things in life. Anyway, life goes on. And first of all, RTS congratulations to Team IMA Tayagaon, Dr. Gopal Gare sir, Amit sir, Narkede, Dr. Narkede, Anish for an excellent conference. Ever since this beautiful 3D reconstruction image of the CT scan was released in from Wuhan in February this year, the world has sat up and noticed an a new novel corona virus which has devastated effects, and it has really crippled the world. And you can see these are the famous ground glass opacities interspaced between the normal bronchial tree. And though this picture looks very beautiful, it has some really devastating effects on the body. Now, though COVID is a multi-organ affection, the main system that is affected in COVID is the respiratory tract system. And all the imaging modalities that deal with respiratory system are the ones which are used to image COVID as well. Now, the classical teaching or the management of a case depended on the what we have been taught for ages together. A good history taking, good clinical examination, investigations, and proper treatment. But with this highly contagious disease, the clinical examination has taken a back seat. The stethoscope, which was a primary tool, has to take a beat a history retreat because of presence of cross infections. And hence the diagnosis and part of the management has rested on radiological imaging as well as pathological imaging to arrive at a correct diagnosis. The various modalities that are commonly used are the humble chest X-ray, CT scan, ultrasound to some extent, in primary imaging as well as to prognosticate the cases, and studies like MRI or angiography and some more when we are dealing with complications and further imaging or in COVID if warranted. Now, CXR and CT scan both are the mainstay in diagnosis. Do they have a role in screening? Well, we are not sure as yet. They may not have a definite role in screening. And the CT scan or CT scan score, if especially the CT scan, if we have a strong clinical history or if there is strong history of exposure to a COVID positive patient. And in such cases, if the RT-PCR is negative, then CT scan or to some extent chest X-ray may also be helpful to diagnose this infection. Sometimes patients come with varied symptoms, may not be COVID-like symptoms, but patient has persistent fever or there is a GI disturbance. In such situations, a chest X-ray or a CT scan may be warranted to rule out COVID infection. And of course, in evaluation of proven cases, to stage the disease, to see how it is progressing, how the patient is responding to the treatment, is it worsening or not? And all these things can be done by these modalities. Chest X-ray, the commonest investigation, radiological investigation. It is very easy to perform. It's available round the clock in most of the places. It's a very reproducible, simple examination. It can be done at a bedside in a portable manner as well. So therefore, no need to transport the patient from one place to other, which again reduces the chances of cross infections. It is low cost and the radiation is negligible. It can be used as a baseline study also. So we can take an X-ray in the initial stages and see how the disease is progressing. It is very good as a follow-up tool, as CT radiation, multiple follow-ups by CT can lead to increased radiation. And in such cases, CXR may be a better alternative. The only drawback of chest X-ray is its low sensitivity. X-ray is low sensitive as compared with CT scan. And in the early stages, it is very difficult for changes to come in chest X-ray. The pathophysiology of the disease is that of atypical pneumonia. And all the features of an atypical pneumonitis will be reflected in chest X-ray patterns as well as in CT scan patterns. The typical damage that happens pathologically is the diffuse alveolar damage because of the virus. There is interstitial, interlobular, intralobular septal thickening, and atypical consolidation and collapses. These are the predominant things that are seen in imaging. So what are the classical features? Now the ground glass opacity, the word has become very famous, GGO. Now GGO is nothing but an area of increased density or resolution, which is seen in chest X-ray as well as in CT scan. This is just an increased area of attenuation, haziness, or increased density, and it is not a very specific thing, though it is seen very commonly in corona, but it can be seen in various other infections or pulmonary hemorrhages and so on. The next is airspace opacities or consolidation. Any material which replaces the alveolar sacs or the alveoli will give rise to what is known as airspace opacities. And these opacities give rise to consolidation. It could be because of an infective material, it could be because of just fluid, it could be because of blood, and so on. But the features of corona or COVID consolidation is it doesn't restrict itself to various lobes as in bacteria or other viral pneumonitis. It is predominantly a lower lobe affliction. Peripheral zones are more affected, bases are more affected. There is no pattern in the opacities. You may get in variable locations. Again, all the features of an atypical pneumonia. You can have multiple nodular lesions as the disease progresses, and complications like effusion and all can be seen in later stages. This is what I was talking about. This chest X-ray was done just an hour before this CT scan done. The chest X-ray is absolutely normal, but as you can see on the CT scan, there is this opacity, a small ground glass opacity with some sort of consolidation happening here. And this was not picked up on the chest X-ray. So for first 3 to 5 days, chest X-rays are not as sensitive as CT scan. However, as the disease progresses, the typical patterns start coming in. And in a study, it has been shown that around 70 to 80% symptomatic patients who have symptoms of respiratory distress will have some feature or the other of COVID. And now we are all recognizes this pattern. Really ill-defined, irregular, small nodular lesions, alveolar infiltrates as we call it, small pleural thickening lines, nodules, or typical consolidations predominantly in the lower zones and in the peripheral lungs. As the disease progresses, the lesions increase in the size, they increase in the density, and they increase in the number. And the pattern essentially remains the same, but the haziness and the density becomes more and more as the progress takes place. And in late stages, you may get features of an opaque hemithorax, associated effusions, dense patches, collapse, consolidation, and so on. Now, these are all very subjective findings. So how do you quantify the lesions? How do you say whether the patient is deteriorated? How do you say that the lungs are looking better? So there are various scoring systems that have been devised. They have been here for a long time now, like old systems like SARI system, in which there are given scores from 1 to 5, where 1 is a normal lung and 5 is severe affection. It could be because of corona, it could be because of any other virus. This is just a chest X-ray scoring system. There's a rail system in which 1 point is given to lungs which are affected less than 25% and more than 4 in stage 4 when there are more than 75%. You add the scores from both lungs and get a score and so on. But the most popular system is what is known as the XXR score, in which we give points 0, 1, 2, and 3, where 0 is normal lung, no infection, no opacities, and so on. While 1 is only interstitium. Interstitium is the backbone of the lung. The various vascular networks and septi which run through the lung is known as the interstitium. So the stage 1 point will be given if only you see interstitial or linear shadows. If you will give 2 points when there is interstitial plus alveolar, with the interstitium forming major chunk. And 3 is when both interstitium and alveolar shadows are there, but alveolar shadows are more. So what we do is we divide the lung into these 6 areas: above the aortic arch, at the hilar level, and below the hilum. And each area is been given points 0, 1, 2, or 3. And then we count it together. For example, this is a total normal lung. So all the scores are 0 in this area. So this has a 0 score. So this is a normal lung with 0 scores. Well, in this area, there is no opacity here, and there's only interstitium or the linear opacities here. Well, in this case, you can see some linear as well as some consolidation alveolar infiltrative area. So this has 3 points. And this has alveolar as well as interstitium, but more of interstitium. So this has 2 score. So together, this lung will have a score of 8, as against this will have a score of 0. So this is a quantitative test, and though it's a bit subjective test, it stands to test of time because you have some figure and you can compare it with future X-rays. Now coming to CT scan. CT scan has really been the backbone of imaging in corona. It has revolutionized workup in cases of COVID-19. It's a very highly sensitive tool, around 90 to 92% of sensitivity. And the only drawback is that it's low specific. This is because, again, I told you the features of COVID are all of atypical pneumonia. So any disease process that causes atypical pneumonia will have features of this. However, if you take into consideration that RT-PCR itself has a modest sensitivity, about 70% or so. So in such a scenario, CT scan helps in many situations. Again, like I told you, non-specific viral pneumonitis. However, an expert radiologist will definitely tell that this X-ray or this CT scan is that of a COVID-19 patient. The CT findings again overlap with those of chest X-ray, the classic ground glass opacity, which could be unilateral, bilateral, small, large, coalescent, non-coalescent, consolidation, again, peripheral, lower lobes, atypical, small, non-conforming to the lobar boundaries. We get pulmonary nodules, reticulations. There's an entity called as crazy paving pattern, in which there is an underlying ground glass opacities, in which are interspersed various thickened interlobular, intralobular septi, which give rise to this pattern. And as the disease progresses, there is a gradual architectural distortion. The normal anatomy is lost. You may get bronchial thickening, vascular dilatation, and traction bronchiectasis, which are some of the complications of this disease. These are the typical features that are seen on CT scan, while lymph nodal enlargement, pleural effusion, pericardial effusion, and so on are not so commonly seen and are seen only as complications or in very late conditions. Like CXR, CT scoring is also there, and CT scoring has helped tremendously, and in which we divide lungs into 5 lobes, and each point is the points are given in proportion to the involvement of the lungs. For example, if the score is 0, then there is 0% involvement. And again, we can just add into that 5%, 5 to 25, 26 to 49, and so on, until we reach to score 5, when there is greater than 75% involvement of that particular lobe. And this, we just calculate the whole scores. So maximum of 5 per lobe. So in effect, the maximum score is that of 25. The minimum score is 0. So a 0 score will be a normal lung, while 25 will have all the 5 lobes with more than 75% of involvement. Usually a stage of around 7 or 8 score is significant and warrants active treatment. Let's hit some cases. This is very early COVID, very suspicious looking small single ground glass opacity. 1 GGO is seen in this peripheral low zone lesions. As a bit more advanced cases, you may see bilateral ground glass opacities, some small nodules happening, interstitial thickening of some degree is there. So this is again early COVID changes. As the disease progresses, there is ground glass opacity, which is bilateral. It has coalesced, it has increased in size. There is fissural thickening, septal thickening, small nodular things, and so on. In very late conditions, you start seeing bronchial dilatation, vascular dilatation, along with some patchy consolidation and irregular ground glass opacities noted in both the lungs. In really late stages, as a complication, there is structural architectural distortion, and you get these bronchial thickening, bronchiectasis, amongst other COVID pathologies. So we got nodules, bronchial thickening, vascular thickening, bronchiectasis, and so on. So what is the role of CT scan? The role of CT scan is primarily in for triage of patients. Which patients to keep, which patients for home quarantine, whom to start with aggressive treatment, whom to shift to ICU, and so on. It can tell us about when the RT-PCR is inconclusive, and a CT scan comes normal, then you are sure that the patient does not have COVID. So you can tell no COVID-19. You can grade whether there is a possibility of COVID being there or not, and what is the severity of the illness, whether it is mild stage or late stage. And of course, in monitoring of patients, how is the prediction, whether it's worsening, whether it's improvement, and in problem solving tools, CT scores a lot. As all of us are aware, is the CORADS scheme, and it tells us about the level of suspicion of COVID-19 infection. And on the CT scan, you can predict whether the patient has typical symptoms or typical signs of COVID or not. And depending on, again, we are given COVID CORADS 1 to CORADS 5, in which CORADS 1 will have no or negligible suspicion of having COVID-19, and CORADS 5 will have a very high suspicion. The CT findings will be of typical COVID-19. CORADS 6 is COVID findings in presence of positive RT-PCR. Let's look at these in detail. So this is a normal CT scan of lung. No signs of any active infection. You could have other features like that of congestive cardiac failure or pericardial effusion and so on, but there is no feature that suggests COVID. So this is CORADS 1, a normal CT. While CORADS 2, there is a low suspicion. There are some nodular opacities, tree in bud appearance. There could be a small patch of consolidation, but this is not typical for COVID. This most likely is happening because of some bacterial or other infection, but this is low suspicion for COVID. As against that, CORAD 3, in which there are unsure or undeterminate infections. There are infections, but they may be very typical, they may not be typical. So you are unsure whether to call them COVID or not. So you categorize into CORAD 3, and you can work them up later. There could be fissural thickening, effusion, and so on. Well, CORAD 4 are the typical ground glass opacities, which are unilateral. There may be some patchy consolidation. So you say that this is highly suspicious for a CORAD 4 for COVID infection. So it's a CORAD 4. Well, CORAD 5 will have bilateral, multifocal ground glass opacities, multiple patchy consolidations, and all the characteristic features of CT that you can think of. And if they're there, then it's a highly suggestive case of CORAD 5, and you assign it to CORAD 5. Well, CORAD 6 is all these findings, bilateral opacities, in presence of a positive RT-PCR. So this is how the CORADS is staged. Now, one of the complications, major complications of corona or COVID-19 are the highly thrombotic stages, which can give rise to vascular thrombosis and subsequent embolization. The commonest being the pulmonary embolization, pulmonary embolism. As you can see, the patient has typical features of COVID. He developed sudden breathlessness and an angio was performed. And you can see the small segmental thrombi or emboli occluding the vessels. Classic pulmonary embolism. So CT scan is very useful in imaging the complications as well. Now we come to the next investigation, that is the ultrasound of lung. Ultrasound of lung has been there for some years now, but has not been very popular because CT scan obviously scores huge over ultrasound in that. However, one of the advantages of ultrasound is that it is a very low cost investigation, and it can be done in bedside. So again, there is no need for transporting the patient from one place to other, which prevents cross infection. And it is very easy test, and it can be especially useful in an ICU setup. There is no radiation curve, it is repeatable, and there is no harm to the patient as such. However, it has a long learning curve, and good training is needed to compete with the kinds of CT features that can be brought out on ultrasound. Now, as corona is peripherally affecting and low lobes, which all are very useful because ultrasound can reach up to these areas and pick up these pathologies. So this is how a normal chest ultrasound will look. The chest wall, these are the ribs, and you can see this white line, that is the pleural line. So this pleural line is important, as an integrity of the pleural line is important in COVID cases. I will see that. So as I told you, lung ultrasound has been there for a long time now, and basic lung ultrasound in emergency, the blue thing, has always been working in ICU setup. And the classic findings are the blue lines. I will talk about them. So these are straight vertical lines which are perpendicular to the pleural lines, and they are because of the fluid in the interstitial spaces, and they are pathognomonic of these infections. The pleura becomes thickened and irregular, and there are subpleural and peripheral consolidations, which are also again brought out by ultrasound. So this is the normal pleura, and these are the vertical B lines, which emanate from the pleura as well as from any consolidated surface. As you can see, there is a small break in the pleural line, and this is a small subpleural consolidation. This is a large patch of pneumonitis, a large base of patch of consolidation. We can see an air bronchogram in the shadow. Again, similar, a subpleural consolidation, a thick irregular pleural line indicating infection, and a patch of consolidation. A large patch consolidation, air bronchogram seen. These are the ribs. This is the irregular shaggy pleura with a break in the pleural line and a large patch of consolidation. So all this can be seen very well on ultrasound. And so we can use this ultrasound again for triaging, for diagnosis of suspicious cases, especially useful for monitoring, and in ICU setup where you can take the machine directly to the patient and screen for such conditions, especially if there is sudden breathlessness or so on. Now, there are various complications of COVID. I'll just go through quickly the CNS complications. If there is sudden alteration in the mentation, or if there is sudden disorientation, if the patient has a history of fall, or there is an unexplained neurological problem, in all such cases, you should be aware that it could be a COVID affliction and you should work up accordingly. The commonest pathologies affecting the CNS system are intracranial hemorrhages. There could be large vessel, small vessels. Obviously, corona affects them, but you could have a large vessel occlusion. There could be acute ischemic strokes or hemorrhagic strokes, and there could be dural venous sinus thrombosis as well. These are the common features that are seen. And depending on the CNS imaging will show acute or subacute infarcts, microhemorrhages, cortical flare signal abnormalities, which are because of indeterminate, ill-defined microangiopathies, which are we are not yet sure of the cause for this. There could be leptomeningeal dural meningeal enhancement, and acute stroke in a major outcome. If this is there, then it has a poor outcome. So we can use CNS imaging also to categorize the disease status complication. For example, this is a microangiopathy. There is a small white matter affliction in the temporal areas and high parietal areas, beautifully brought out by diffusion weighted images also. So the white matter disease problems are common. A large MCA infarct, you can see the black MCA sign, non-enhancing on contrast, and you can see a big infarct in the MCA territory. You can see a large infarct in the cerebellum, a large infarct in the high parietal and splenium area of the corpus callosum. Again, an hemorrhagic infarct in the area of the MCA involving the caudate nucleus, the internal capsule, some part of external capsule, insular cortex, etc. And you can see on an angio the M1 segment of the MCA showing narrowing and occlusion. Bleeds are also very common, especially if in cases of the patient suffers trivial trauma. There can be large bleeds with mass effects and compression surrounding vasogenic edema and so on. You can have venous dural sinus thrombosis, which may lead to hemorrhagic infarcts or bleed. As you can see, the straight sinus and right sinus are affected, and there are multiple infarcts. An angio, this has been brought up very well. So this is about the classic imaging in Corona-19. So the take-home message is that imaging plays a crucial role now. So in this highly contagious disease, when clinical examination has taken a backseat, chest X-ray and CT scan are very helpful in triage and in prognosticating the disease, very useful in monitoring the patient. USG is important in ICU setup. You must watch for complications and intervene at the appropriate imaging and appropriate time. Thank you for your patient here. Thanks a lot.
Thank you, sir. I request our chairpersons to put some comments and also questions, sir.
We all know that CT scan has really helped us for diagnosis of COVID in suspected cases. And radiology was very important in managing COVID, especially many cases wherein the RT-PCR test was negative, the sensitivity was low, and the radiology really helped us to solve whether it's COVID or not. And sir has rightly described the techniques and the scoring system and how they suspect or they confirm the diagnosis of COVID. So very nice presentation by sir. If anyone from the audience has any questions, they are free to ask.
I hope you can post your questions in chat box. Thank you, Dr. Savnis, sir, for such great enlightenment on this imaging in COVID. Sir, here is your appreciation shield.
Thank you. Thanks a lot, everybody. Thank you.
Thank you, sir. Thank you. Now we are moving towards the end phase of our TIMACON 2020. As a last phase, we have a panel discussion, and I request our organizing secretary, Dr. Dattatreya Gopalagire sir, to come as a moderator for this panel discussion and introduce our panelists also. Before moving ahead for panel discussion, I request our chairperson, Dr. Santosh Bokar, sir, to felicitate Dr. Mubarak Khan, sir. I request our organizing chairperson, Dr. Amit Kulkarni, sir, to felicitate our chairpersons for this second session, Dr. Santosh Bokar, sir, and Dr. Yuvraj Bhatt, sir.
दोघांचं झालं काय फोटो फोटो
Thank you, sir. Now we will move ahead with our panel discussion. I hand over the mic to Dr. Gopalagire sir as a moderator for this panel discussion. Dr. Anish has been constantly doing this anchoring business since morning, so I thought I'd take over and give him some rest. Thank you, Anish.
Thank you, sir.
I request the panelists for last session. Name of session is Conquering COVID. We have already conquered actually.
but the T is probably remaining, which will remain for I don't know how many years. So to learn from our experts, I request Dr. Zategaonkar sir to be on the dais. I request Dr. Mubarak Khan sir again, Dr. Santosh Borkar sir, and Dr. Yuvraj Bade sir. Now, out of these four panelists who already we are introduced to you and they have delivered their own talk or lecture related to COVID. So I'll start with introduction. Dr. Srikant Zategaonkar sir is one of the most senior most physicians in Talegaon. He is faculty at Mayapur Medical College and director of Dharmeshwar Clinic in Talegaon. Sir is physician as well as I can say he himself had suffered COVID, recovered out of it very successfully and now guiding all of us to get out of it or get over it. So sir has been really a true guiding force for all of us working team of IMA. So thank you sir for being here and I'm really happy to have you here. Dr. Santosh Borkar sir, he is orthopedician, he is professor and HOD of Orthopedics, Mayapur Medical College. He has done his undergraduation from Sassoon and post-graduation from JJ Medical College, Grand Medical College, Mumbai. So we are going to balance something like MD and MS or physician and surgeon. So sir will be something like surgeon and will help us to look after surgical aspects which are to be managed during COVID. We have two more panelists, Dr. Mubarak Khan sir, who is ENT surgeon, already spoke a lot. Probably the longest talk of today's conference was delivered by Dr. Mubarak Khan sir, and he has already announced rather to sponsor Dr. Dilip Bogesar Foundation in next coming 50 or rather 45 TIMACONs. So I'm grateful to you, sir. Sir has been a researcher, innovator, teacher, guide, friend, trainer, singer, dancer. I don't know what rest of things he does. So, thank you, sir. And Dr. Yuvraj Bade sir, who is a chest physician as well as a general physician in Talegaon. So, we have two surgeons and two physicians. Most of things have been already spoken. As I told you, two speakers have already delivered their talks. So, two panelists who are very senior and they haven't given any talk per se. Dr. Zategaonkar sir had his own presentation, which is very relevant. As I told you, not only as a physician but as a COVID survivor, I can say. So I request Zategaonkar sir to share his presentation in the beginning, so that we can have view on his experience about COVID, and then we'll proceed in the panel discussion. So I request the team to connect PPT to Zategaonkar sir's presentation. Sir, you can start.
At the outset, I thank the team of TIMACON for inviting me here. At the outset, I thank the team of TIMACON for inviting me here to share my views. And it's great going since morning. I am attending it online. We started with the how to convert our negative thoughts into positive thoughts. Lecture by Dr. Anish Bhatt sir with a lot of spirituality imposed on it. That was really great start. And after that, we learned many aspects of oxygen therapy from Dr. Yuvraj Bade sir. That was also quite enlightening and rich in knowledge lecture. Then, of course, we had some inaugural session, and then Dr. Khan's inventions last lecture before this. That was also great, and I wish Dr. Khan's creations all the best to continue and be a bright star in the IMA Talegaon Dabade, and which shines worldwide. By the way, today there is some constellation in the astronomy that Jupiter and Saturn are going to come very close, and this is going to happen in 600 years. So we are lucky in a way to witness this. Same is the situation with the pandemic. It is, I don't know whether we are fortunate or unfortunate to witness this pandemic, but as a doctor, physician, I really feel it's a great opportunity for the doctors to serve the society. So I'll quickly start with some slides. Conquering COVID-19 is the topic given for panel discussion. And Dr. Gopal Ghare sir has already announced that we have conquered COVID-19. Thank you, sir. It is acute immunogenic thrombogenic inflammatory viral disease. And today, this is 11th December toll, we can see there are confirmed cases in India, uh, almost 1 crore. Am I right? 98 lakh 27,605. So almost we are very close to 1 crore population who are confirmed cases, and population is 130 crore. So I was just trying to read what happened to last pandemics over last 1,000 years, 1,500 years, and went into the history and found some interesting aspects of pandemic. This is the Maharashtra toll, 18,72,440 confirmed cases, and there are still active cases. And if you see, daily there are 4,000 cases, 4,268 new cases on December 11. So daily there are 4,000 cases are coming positive. That means COVID is still with us. And as Dr. Khan sir rightly told, we may have to live with COVID. So these are some interesting aspects about the COVID-19 pandemics. These are influenza pandemics. Most of the pandemics are because of influenza virus and believed to have occurred unpredictable intervals for many centuries. Outbreaks of swine flu are common and cause significant economical losses. Influenza, the flu, is believed to have been around for a few thousand years. Hippocrates, who is considered to be the father of modern medicine, has described symptoms of the flu in 412 BC at printouts in North Greece. So that is that old. Of course, the data and literature may not be available, may not be authentic, but that's what I got from the various sources. Then there are a series of pandemics, 855 in Persia, 1485, Britain, flu-like symptoms killed thousands of people in Britain, including the mayor of Britain. 1510, a flu pandemic originated in Africa and spread across Europe. 1580, a pandemic originated in North America, then Europe, North America. 1688, 1699. So these flu pandemics were not new to the time. 1729, a pandemic in Russia re-emerged in Sweden. Then 1781 to 82 in Rome, 3/4 of the population was killed. Then 1789, then they are coming closer and closer. 1789, England, New York, Nova Scotia, most days appear to have been secondary pneumonia. So it is respiratory flu-like, and at that time the agent may not be isolated, but history suggests that it is similar. So then coming to in 1900, a major epidemic was reported in North America, England and Wales. 1918-19, the worst pandemic so-called Spanish flu, that are the various pictures are also available, and affected nearly 1/3 of the world's population, caused 50 million plus deaths worldwide. This is the picture in 1929-1920, 2 years it lasted, not 1 year, and isolation, testing, I don't know whether it was available or not, but isolation was the treatment, and some household remedies like steam inhalation, and that they have been there. So this is the picture of quarantine in 1918, and people used to wear masks, were attending the theaters for a couple of years, maybe after that also, though amongst the 4 of us, only 2 are wearing the mask. I don't know why. Pandemic is going on. And in 1957-58, avian influenza originated in China, with deaths worldwide estimated between 1 and 4 million. 1977, Russian flu. 1997, avian flu, Hong Kong. Then this SARS. Everybody knows this, and most of us have witnessed this epidemic. And this also originated from the Guangdong province of China in 2003, and H1N1, what we used to call, and that has also affected quite a good amount of population in the world. Now, looking at all the pandemics, these all viruses were initially believed to be from the animals, from the bats, from camels, then from swine, pig. So how these viruses entered into human being and found the human being as new host, that is still not known. So transmission from animal to human being, how it has occurred is still unknown to us. So this again, that always many of the pandemics, China is the source. Guangdong, I have seen H1N1 in 1956 also, this one. COVID-19 also, one city of China, everyone knows that in December, early December, 47 cases of atypical pneumonia were found. They started investigating what is the agent. And this is airborne disease. And why there is connection to China? Why maybe there is population is largest amount of population lives there, and their food intake is connected to the animals. That's what I guess. Maybe because of that, these viruses are getting transmitted to human. That is one reason which I think could be possible. And being an airborne disease, the word airborne has a dual meaning. Airborne means respiratory secretions, droplet transmission. That is true. But to my understanding, the before 1918, the air travel was not that common. The flights were not that much. Today, every day, I think 10 lakh people travel from one country to another. Earlier than March, I mean, before there was a pandemic was declared by WHO on 11th March. Before that, all flights were in working conditions. So that is the reason why large amount of world population is affected. From December, January, February, there was no control over the air traffic. So this is another word for airborne disease, which I think with this introduction, I request our moderator, sir, to take over. If there are any interesting slides, I will be back.
Thanks a lot, sir. You took her back to 400 BC and to 2020, and almost COVID is not there. Thank you. Now I request Dr. Santosh Borkar, sir, to guide us regarding the surgical orthopedic practice. In general, in surgery, what are minimum things one has to follow in emergency and for elective cases?
To begin with, I was never imagining that we will have to stop operating for a few days, because as a surgeon, I never stopped operating since 2002. I never stopped operating any day. I don't remember any day when I did not operate anything. And for the first time, a thing happened that for a couple of months at least we were told to stop all the elective operations and go ahead only with emergency operations. So that was a major thing that happened. And then we were told to decide which cases to operate and which cases not to operate. So most of the time, we never had any such concept that we have to stop operating some cases. So like joint replacement or some elective surgeries, where totally they were said that you call after 6 months. So first of thing was to decide which cases to operate and which not to operate. And then when the next thing that happened to our specialty was despecialization. That is, they said that you are no more an orthopedic surgeon, your residents and you all are just MBBS, and you have to manage everything at MBBS knowledge. And it is seen after 20 years, no questioning of the knowledge was done for the medicine, and suddenly we were bombarded with all those. There's so many guidelines coming from ICMR and WHO, and we really went through all that and we freshened up our knowledge a bit. But then, anyway, surgeons are surgeons and they cannot replace the physicians, and that some luckily might have remained from our side. But we did all our best to handle even the COVID patients, and our residents and our faculty all were posted in the COVID wards on rotation basis, and still we are still doing the excellent work now. That had occurred for us. Now, as I told that we had to select which cases to operate, and then how to go ahead with some operations. Like we were told that you have to suspect that every patient is a COVID positive patient. If he has some symptoms or he has fever, cough, or whatever other complaints, we have to screen him and take proper history, and that we all did. And then, whenever possible, we stressed all the contacts and travel history and everything. And then we went ahead with them in very few centers. So for a smaller orthopedic surgeon, this might not be possible. So some of them totally closed the operative procedures at all. But then after a few days, everyone got guidelines, and then they started doing COVID test. And on admission, only the COVID test was done. And before surgery, also the COVID test was repeated. And these suspected patients were kept in a separate isolation ward. And after that, if the test was positive, they were given some minor treatment so as to postpone the surgery. And then after a few days, when the COVID test was negative, then only they went for surgery. So this was the procedure that was followed. And regarding the operation theatre, there was a lot of changes that had to be made. Like previously, people were operating on single ply mask. All the surgeons and patients were not wearing any mask at all. They were directly brought into the operation theatre. Then here it was the change that patients were put on single ply mask, and the surgeon compulsory had to wear N95 mask and face shield or goggles for safety. And some procedures, even PPE kit, especially if the high risk case was there, suspected case or confirmed case, then PPE kit was a must. And that had to be worn by everyone, including the surgeon, the nursing staff, the ward mama, everywhere. And thorough cleaning in the operation theatre. All the contact surfaces, even the trolleys, the shifting, the lifts from the ward to the operation theatre and operation theatre back to the wards, everything had to be cleaned thoroughly. And in which the fumigation was repeated fumigation before each case, after each case. And then in that case also, while operating, minimum people should have entered the OT. That was care was taken there, and even the minimum, even the residents and the fellows were told to be outside if necessary. But only the proficient surgeon could perform the surgery within a very short period of time, so as to decrease the exposure to the patient as well as the surgeon. It was pretty well decided, and the limited number the implant persons were told to wait outside. So, and all the autoclaving was repeated again and again if there was any problem before. Because some of the implants, people being the autoclaved implants, we autoclaved them instead of directly taking them into the operation theatre. And then there was special precautions had to be taken, like pottery use was minimized. Because it was said that the pottery use causes much spread. And for the anesthetist also it was very difficult because for the anesthetist, intubating and such GA procedures were very difficult. So they were told to concentrate more on the regional anesthesia. And then also while operating, they were told to wear all the face shields and N95 masks and everything. And again, the operation theatre, first thing that was done was there were no ready-made operation theatres for COVID. The first thing they were told is to stop using air conditioning. So air conditions were totally stopped, and then negative ventilation was, as Mubarak said in the earlier, but it was not possible to install HEPA filters immediately, and the negative filter ventilation was not possible all of the time. So only thing that we could do is we stopped doing AC and we installed some negative exhaust fans in the OT, and then we made designated OT for only COVID cases. Like apart from the routine OT, one special case OT was made which had all the necessary equipment, and that equipment was specially used for only that cases, not for the general other cases. So special equipment, special OT, special staff, everything was made for COVID or suspected patients was special. And then as far as orthopedics was concerned, we were using a lot of power levers and drills and all these power instruments. So we, as far as possible, tried to avoid their use and use manual instruments. So that was a bit difficult, but because we never had, we had lost touch with the manual instruments, we had to revise them. And then we operated with all the new precautions, and then shifted the patients properly into the recovery room. In COVID patients, they were not kept in recovery room, they were kept for extra period in the OT itself, and then they were directly shifted to a COVID ward. So all these precautions had to be taken, and at the end of it, we could minimize the complications, the number of personnel who were getting This was a dramatic shift in our approach, surgical for surgeons, as far as COVID was concerned.
Thank you, sir. Now, I have very few questions on behalf of those people who have either not attended it completely, or they were not attentive, or they were confused or something. So, very simplified questions. I request Dr. Bade sir to answer or throw a light on how do you distinguish between a simple common cold of a general practitioner from COVID-19 in very simple words for everyone. Like I am a gynecologist, so I should get it.
It is simple question. Simple question, but very difficult to answer this because in this pandemic situation, it is very difficult to distinguish whether this common cold is because of any other virus, bacteria, or it is because of COVID-19. But what we are doing in our OPD, that just using this antibiotics like doxycycline and ivermectin for 3 and 5 days, and if the patient is symptomatically not better, then we advise them to do RT-PCR test nowadays. But previously it was mandatory to do this RT-PCR for
मला अगदी हे झालं रे बड्डे सरांच्या background मध्ये फोटो लावला.
Okay. Now I just one minute. Yeah. Radhegowkar sir has something special related to this question, so
Just would like to share a slide.
I'll clarify it for non-physician group of clinicians.
Please allow me to screen share. I found some literature on how to differentiate between cold, influenza, normal influenza A/B, and coronavirus. Time between catching the virus and beginning to show symptoms is 1 to 3 days in cold. Though this is arbitrary, I mean, this is not, cannot take as a gold standard, but I think that's what the literature says. You can say that runny nose is rare in coronavirus. Sore throat is also less common. Then differences between the cold and the coronavirus. Difficulty breathing can be common. It is commoner than the cold. And with the runny nose, sore throat, you can diagnose more as a common cold. If there is loss of sense of smell or loss of sense of taste, you can label him or send the patient for RT-PCR. That's all.
Okay, thank you, sir. Now I request Mubarak Khan sir to put some light. How did he manage his practice, his OT, his life per se before there was any guideline? Very much beginning, 15, 20, 30 days when there was nothing advised by WHO or by ICMR. What was the situation? Because if you see, ear, nose, throat is all the source and full whole bank of COVID. So if they were dealing with that, they could have stopped working in elective cases, but definitely emergencies they were handling. So just enlighten us. This will help us because COVID is there and it will remain. So for at least those cases which are asymptomatic or unknown or you are in emergency, so how did you manage when there were no guidelines, when you were not aware of your own beta?
Yes, that's really a fantastic question, and that was called the rapid situation. In January, February, till 25th of March, Dr. Khan was operating 30, 40 cases per month, and suddenly one day they said stop, and we stopped. Even if we stopped only the routine cases because we can push it, but the cases which we face daily is the foreign bodies. It's routine. The children's, they put so many things in the nose, so many things in the ear, and they even children's, even the adults with the fish bones, chicken bones, so many things. So and as Dr. Gopal sir has mentioned that this is the house of corona. You say and thousands of viruses are out. So we were literally terrorized. I know my anesthetists, they need to be very much terrorized because they are putting the ET, and whenever they are putting that ET and all, that was really problematic. So when beta-D was not there for the first one, and also what we used to do, I just gone to the CDC. At that time, no guidelines were anywhere in the world, but only we came to know that sodium hypochlorite is a good thing. So we started only sprinkling in our OT, even done a double fumigation. Again, Dr. Worthal mentioned like that, we reduced the staff, people coming inside, and whatever extra thing which is added due to the anesthesia, because anesthesia suggested at least we can put a HEPA filter into that endotracheal tube. So we started using that. So for 1 month, almost we reduced the work for like anything. Only those small emergency cases we used to do with those things, and with PPE. Obviously, that PPE was there, so we used a lot of PPE, means our routine gloves, face mask, and face shield for us, for the anesthetist, and for the staff. So, and we started taking we made a small box at least at that time with we use a microscopic cover. So we made one small shield so that the anesthetist can put little nicely and little bit aerosol generation will be less. So for 1 month we tried like this, and later on, then I have talked about the whole thing about this.
Now I request Dr. Yuvraj Bade sir to put in few words or few lines what are the current effective approved safe drugs for treating COVID at home, in a simple hospital, and in critical care.
Okay, then there are two situations. There is one patient is COVID positive but asymptomatic. Then the strategy for treating asymptomatic patients who come positive, we advise them to home isolation. And what we are using is doxycycline for 5 days, ivermectin for 3 days. Is oral medications, vitamin C, and proper use of mask, strict home isolation, and frequent use of sanitizers. So those, and we always ask them to observe their saturation at home and maintain it more than 94-95%. If there is any symptoms like fever or breathlessness and saturation is going down, then they are told to get admitted in the hospital. Now, the next comes COVID positive and who needs hospitalization. Means then we categorize them depending upon their severity, like mild, moderate, and severe. And depending upon this mild, even if they are mild symptomatic, we advise them to stay at home. But if it is moderate COVID positive pneumonia and severe pneumonia, they are advised to get hospitalized. And when they get hospitalized, depending upon the condition of the patient. Now, from start, we are seeing so many drugs like hydroxychloroquine, then it went out. Then we got favipiravir. But favipiravir, we used it in mild to moderate cases. But after we got the remdesivir, we used remdesivir instead of favipiravir in moderate and severe COVID positive patients. Then they are hospitalized. When after doing these routine lab investigations and some inflammatory markers, if there is any cytokine storm, then we have used tocilizumab, and we have used tocilizumab up to 3 doses in patient. And but strict we did their inflammatory markers as well as procalcitonin levels. Means we ruled out other bacterial infections, and then we offered them tocilizumab. Then other things like steroids and low molecular weight or heparin, if they are admitted in ICUs, or sometimes they are having hypoxia and they need oxygen. So in such a way, we manage these patients. And some drugs, actually, in one setup, we use this magnesium sulfate and methylene blue also. Methylene blue actually it is I don't know, but we have got very fantastic results with this methylene blue. We use this methylene blue as an antifibrotic and it is fast acting. And in patients who, after giving remdesivir, methylprednisolone, heparin, 3 doses of tocilizumab, and the so-called convalescent COVID plasma, after giving everything, still the patients are hypoxic and they need oxygen more than 10 liters. In that patients we tried this methylene blue directly by injection. We diluted that and by regulation, and we found that. And I'm again happy to share that by using this methylene blue, there was not a single mortality in ICU which we have managed. So in such a way, and the most superhero, as I talked in the morning, that is oxygen and judicious use of oxygen. And we used ventilators, non-invasive ventilators for severe hypoxemic COVID positive pneumonia, but with very judicious use of oxygen. So that's we manage the patients with COVID positive patients.
Thank you. Now I request Adegavkar sir to just say a few words on what things one should observe those who have already recovered from COVID. Like half of us in this hall and maybe 30% in the audience online would have definitely contacted the infection. Very few are fortunate like me. So what they should keep watching for themselves or their parents or their family members. And on serious note, it's gone because it's very well proven that few months, even these antibodies will be disappearing and you may get a new lot or a new slot or a new version of the virus inside your body. So what should we watch as a post-COVID syndrome or effect on recovery basis?
It is very interesting and markable question by moderator sir. I was trying to read about what is the end game of all these pandemics. What happens? What happened in the history? How these pandemics ended. So, according to the medical scientists, they believe that herd immunity is one solution. When the 70% of the population, the 70% has come according to the R0 of the virus. R0 of the virus is ability to attack different persons by one case. This R0 is 3, so one person going to infect 3 persons and 3 persons going to infect 3 more, so one person infects 9 people. According to that, according to this formula, if 70% of the world population gets infected or gets vaccinated, then the pandemic will be under control. So, these antibodies believed to last for 6 months because now there are 12 months of study from January to December. COVID has come. From July 2020, some vaccine trials have started, and there 2-3 vaccines are in phase 3 trial, and result will be available by December 8. And from first week of January, the vaccination will start in some countries, and that also with the prioritize the population, first healthcare workers, then elderly people, then patients with major medical illnesses like diabetes, hypertension, COPD, and ischemic heart disease or cancer. Then the other population will be vaccinated. So with this speed of the research of vaccine and with getting infection by the 70% of the world population, I think it will take definitely 4 to 6 months more to vaccinate that much percentage of population if and only if governance is efficient in all the countries to carry out this vaccination program. So till that time, those persons who have suffered and as a healthcare professional, those who are at high risk, they should not assume that now we are free and now we won't get any infection, because it also depends on the dose of the virions. When the patient comes to your OPD and he coughs or sneezes, and there are thousands, millions of virions are liberated and to examine the patient, we cannot be more than 1 meter or more than 2 meters away. We have to come closer. And I don't think all OPDs of all doctors are equipped with negative pressure, exhaust fan at the back of the chair, and whatever he has exhaled, that is absorbed by the exhaust fan and thrown out. This is not possible practically, so we should continue to take precautions, SMS, sanitizer, mask, and social distance.
Okay. Thank you, sir. Now I go to Gorkar, sir. Like, it's something now we all, the most of you are sitting are around 40 and 50, I'll say you may be above 50. So COVID has really made people thought when you should stop practicing, when you should limit your practice, when you should contain your social contacts, which are not really essential. So, what do you think as orthopedic surgeon? You said like you had a bad feeling you were not operating. But suppose similar things keep on coming. There was one epidemic or pandemic of medical legal cases, which is very much there, which is always behind. Nothing may happen with us, but one of our colleagues gave shoes, and for a month we keep on thinking and talking about it. So, do you have any personal suggestion at one point? A consultant doctor or a surgeon should curtail his work or practice or change the way he practices.
Actually, for young surgeons, this is not a choice at all.
Young at heart or bones?
Whatever he considers himself young. But the problem is that probably for early retirement. So that could be an option for those who are economically sound and have their children have well settled, and then they can go for such early retirement. But otherwise, for others, most of the time, I don't think there is any choice. The choice is to protect ourselves. That is the only choice, that you take adequate precautions while seeing the patients, and say social distancing is not possible. Is rightly said for doctors. Patients cannot be seen, but the way that Khan sir had already said, that how to minimize contact and how to minimize the aerosol generation and how to get rid of those viruses. So that precautions have to be taken. Regarding why one should stop practice, actually it is an individual decision. So everyone in the world is going for early retirement. We ourselves are doing day and night work, and actually we are, as the IMA itself has done studies, we say that the life of the doctors is 10 years less than the general population. So that the stress is really taking a toll. And why so many doctors have really died in COVID period? So it's like Bogus also, because they have worked so much throughout their life, they have not cared about their their life at all, and they have worked selflessly for the society. Now it's how much to work for the society, that is also a very big question, because as you said, the pandemic of medical legal cases is really coming up, and no one is being spared. How well work you have done throughout your life, but one big mistake, one death, and you are smashed. So that really is the reality of today. So actually, but for this, in one Maharashtra Orthopedic Association, they have said that you will look for alternative income also. So if you are really able to manage some alternative income, alternative investment, wherein you are able to get good amount of money even without working, you can think about retirement. But for many surgeons, it is really not possible, and many of our doctors have been into studies only and into practice only. They have not learned any other skill. So we should try to acquire newer skills which are possible to acquire, and try to see if they can be converted into our career or alternative source of income. But at present, I myself am not into that category at all. So how others are going to manage is their own perspective. Yeah.
Okay, sir. Thank you. You spoke about choice, and in gynecology we have a choice which is there in public, and some people don't use that choice. So it's same, people have options, but they don't use them. So you already took me to another topic which was in my heart rather than which is again necessity. Now I request Mubarak Khan sir to guide in simple words about generating the alternative income or becoming a small entrepreneur.
Yes, and he's very well put forward the point. If at all you want to avoid the corona, the best practice is not to practice. Okay, but if you stop practicing, then your EMI is there. Then there are a lot many commitments are there. How to do that? Everyone has got the talent. Believe me. Anish Bhatt is there. He loves trekking. If now you have a virtual platform, let him just take a photograph. Let him just create a nice, beautiful presentation. Put a webinar. Now I give a webinar with the charges. I take webinar for my courses because my things are stopped. My master classes are stopped. But with webinar, like a registration, put a registration, 5,000 rupees registration. 1 day of continuous talk. There are some 15, 20 people who are interested, they will register. Because now you have a platform of the whole world, not only localized here. So you can do everything. Some are culinary specialists. My friends, even my young friends, they have started their YouTube channels on culinary. Nice, making fish, wow, and then they're getting the audience marketing on the webinar. That's one thing. Another thing, if you have a talent, bring it. You must be liking the engineering. I am actually an engineer. I love engineering. One day my father said, son, पूरे खानदान में डॉक्टर नहीं है, जा डॉक्टर बन गया. But I am reviving that engineering thing, and these are all. So if you have got that, do it. One of my friend, orthopedician friend, you must be knowing Bhushan Patil. He's a professor in UL. He revived his singing, learned singing, now doing the with singing and so alternatively, he has become again a very much good investor in shares. Believe me, the shares which have started, because when I entered again in the Talena, I was doing the shares. Sensex was 4,500, believe me, 4,500, and today is 45,000, 1,00,000% profit. Just you have to hold. That also I do. Okay? Because simple now you are by sitting here with this mobile. I have an app, zero down. But don't do that day trading. Think about just simple 5-10 companies. उतना ही लो उसको रोको. 6 महीने कोरोना के पहले लिया हुआ था. आज 100% प्रॉफिट. बजाज फिन सर्विसेज 100% कहाँ कौन से धंधे में मिलेगा? और रिस्क फ्री एंड बाय. Imagine Gopal Garu is sitting inside. चलो यार 5 ही मिनट देना, चलो 2 खरीद लिया. सुबह में जाने के राउंड के साथ 2 शेयर्स खरीद लिया. शाम को जाने के पहले 10% हो गए, ठीक है, चलो बता दो. Number one thing for shares, don't be greedy. Don't be greedy that अरे ये लूज किया. You decide your aim. मुझे 10% चाहिए, मुझे 20% चाहिए, बस. बाद में 30% पे गया तो बुरा मत ले लेना. No stress free business. Number one thing, no stress. So alternative things are there. Don't worry. And the corona has opened up many other things. आज तो fish और chicken भी घर पे आके मिलता है. One of my friend has started just as one app to deliver the things. किराना माल का ये 50 इससे शुरू हो गया मेडिको. So there is an alternative. Do your practice. I love practice. There is no problem. लेकिन corona has changed my thing. I have curtailed evening OPD. I don't see the evening OPD now. From 11 to 5. That's all. 5 बजे के बाद भंडारा पे जाओ. शाम को आओ, किशोर कुमार का गाना गाओ. इसके ऊपर बैठे 2 वेबिनार ले लो. That's all. So there are the things. So just हर एक में होता है. सिर्फ उसको थोड़ा बाहर निकालो. वो मत बहते जाओ उसी में 24/7. That also I have done. अब यहाँ से मैं खोपोली तक भागने का, कल से भी करने की. वहां तक, वहां से रायगढ़ तक, यहाँ से इधर पंढरपुर, सब भागने का. लेकिन अभी घर पे बैठ के भी है, ऑनलाइन है, वर्चुअल प्लेटफॉर्म है. Lot many things can be done. Revive it back. Don't take any tension and do your practice happily and without stress.
Thank you, sir. Anybody here in the audience who are physically present in front of me, anybody has any doubt, query, question for these people who are there whom we went? ask anything. If not, I make it open to the audience, those who are still present with us online. So anyone has something, they can unmute themselves. Here we have our MOC has some questions. So Dr. Anish, please.
I just want to ask the panel about the opinion regarding the vaccine, which is going to come recently in a few weeks.
He's very optimistic and he is saying it is going to come in few weeks. Okay, 3-3 weeks.
You know,
Let's see.
Let's be optimistic.
I know. Lecture on optimism, that was nice. Sir, please. बोलूनच सांगायला सर
खाली शेअर yes.
Technology doesn't easily follow the wisdom probably. Sir has made so many things, but you know, the screen is hesitant to get shared with people.
It's not moving.
It's not very clear. You can read it out. Your words are more than literature, sir. Don't worry.
Hang program. There are at least 200 vaccines are in pipeline manufactured by different countries. And there are various types of vaccines, live attenuated vaccine, then killed virus vaccine, then parts of antigens. Now we are learning about mRNA vaccines. So different vaccines have got different advantages and disadvantages. The vaccine which we are closely seeing in the future is Pfizer vaccine. Only problem is that it needs ultra cold chain to storage, that is -20 to -80, and that will be quite cumbersome in our environment. So that is one. Then another vaccine manufactured by Serum Institute of India, Punawala, that also he has purchased from some other company, and they're jointly manufacturing it, and doses are ready. That is not live attenuated vaccine, but it has 70% efficacy. Pfizer one has got 90% efficacy. Another one, Moderna, which is available in US, which where the vaccination will start in the next few weeks, that has got 94% efficiency. So there are different, what we will be getting, most probably we will get 70% efficacy vaccine, and mRNA type. mRNA vaccines are notorious in that they bypass one membrane. So the vaccine, the virus particle antigen has to enter only one membrane. So that is the advantage, and the manufacturing of antibodies they don't have to enter the ribosomal membrane. They just enter the cell, and then mRNA starts production of viral antigens to which our humoral and cellular immunity responds, and then the antibody production starts. That is the mechanism. Then there are different conjugate, which I don't have a slide to show you, but there are different mechanisms by which we are trying to boost our humoral immunity. And for all the vaccines, at least 2 doses are recommended. The interval between the first and second dose is not yet defined. And once the WHO approves, there is one accelerator program of how to deliver all these vaccines manufactured by different countries to all the world population. That ACT agency has got a lot of funds from charitable institutions, and using those funds, they are giving it for manufacturing and distribution of the world population, depending on the priority of the people. And they have, as I already said, they have prioritized the category of population, initially healthcare workers and ambulance drivers, etc., and then elderly population, patients have major medical disease, cancer, etc. And then children, it seems that children are not exposed to different antigens. That's why they don't suffer from autoimmune disease, and that's why the corona in children is less severe. I don't know if there are any pediatricians. So children also will receive vaccine, but the decision is pending, and that's how I hope the vaccination of world population progresses, and we develop 70% immunity and the pandemic ends. Let's hope for the best.
Thank you, sir. Now I request Dr. Anish Bhatt sir to take over again, and I conclude this small panel discussion attended by various specialists from all the corners of Mawar. Thank you all. Thank you, sir. Thank you, panel. Thank you, wait for 2 minutes for the felicitation. I request our chairman of organizing chairman, Dr. Amit Kulkarni sir, to felicitate our panelists, starting from Dr. Jatigampa sir. Dr. Mubarak Khan sir. Dr. Santosh Kulkar sir. Dr. Yuvraj Bade sir. Last but not least, our moderator of the panel discussion, Dr. Gopal Gare. Thank you, sir. So, with the end of panel discussion, we have come to the end of this TIMACON 2020 conference with lot of old memories, new dreams, and lot of new teams and whole lot of new work ahead. So I request our organizing secretary, Dr. Gopal Gare sir, to present the valedictory ceremony of this conference, and I request him to come on the dais and please present the valedictory. They say nothing is permanent, neither we nor the conference nor the audience.
Please turn on the mic. We cannot listen.
Have changed, values have changed, rather. And there are many WhatsApp messages actually. They say like nothing is sort of going to guarantee you of your life or existence or safety or comfort or satisfaction or success. Very different. I'm here to do the most important job. According to me, one lands up teaching their students or children meaning of gratitude, practicing gratitude, executing gratitude, living in gratitude, living with gratitude, probably no terrorist organization will come up. There won't be any hatred, there won't be any grudge, there won't be any worry, there won't be any sorrow. But it's difficult, it's easier to say. In the beginning, in one word, I can say I thank everybody, but that will be injustice to the job done by my fellow colleagues, my seniors, my team per se. So to start from the day, very much in the beginning, I am grateful to Dr. Anish Bhatt, who is accidental master of ceremony, emergency master of ceremony, but since he is a trained psychiatrist, he can do that. So thank you very much, Anish Bhatt, and I hope you continue this role of accidental MOC for us. The moment we get a better, fair, smarter option, we will replace you, but we will call you again definitely. Thank you, Anish, very much. Then we had different speakers. The first talk was very much by Anish, so I thank him as a speaker as well. Then we had superhero oxygen in form of Dr. Yuvraj Bade, young budding chest physician and physician. musician. I'm really grateful to you, Raj. He's part of our team as well. Thank you, Raj. Then we had very important talk. Somebody had clicked some photos about social security scheme. Friends, I have not yet enrolled for this. I wanted to, but I thought I'd take a group of people with me. But now, even if there is no group, I'll enroll alone. Some 5 to 6 members from Talegaon IMA had enrolled long back, including our mentor, late Dr. Mugi sir. But when I found out recently after his demise that probably nobody has continued it. Friends, you start something and you don't continue, it's almost like not done. So those who have taken social security scheme, we should continue. Those who haven't taken it, we must take it as early as possible. It is one of the most easily available, very financially sort of feasible sort of social security scheme compared to any insurance, let it be LIC or let it be private insurance. So I urge, I request all my members and the audience to go for social security scheme, and I'm really grateful to the social security scheme chairperson of state of Maharashtra, IMA, Dr. Marathi sir. Then we had fitness mantra by our own Dr. Dilip Sada sir, who never says no to anything that I say. Earlier I had already said he is good friend of Dr. Dilip Boge sir, but at one point, though I am very younger to him, he behaves with us as his true friend. So I am thankful to Dilip Sada sir. Then we had the big boss, state president, IMA Maharashtra, Dr. Avilash Mondre sir. Believe me, a state president coming to such a small place, Talegaon branch of 70 members. He was in Mumbai yesterday for his own meeting, where it was a sort of a difficult meeting rather. And still today we could make it physically to this hall only for love of our boss, to felicitate him posthumously. So I'm really grateful to Dr. Avilash Mondre sir, and I wish him all the success. He's very patient. We attend many meetings where many times like I'm a bit short-tempered. Everybody knows those who are around me. So yesterday people were talking to him all rubbish, but he kept quiet. And after some time, there were people who came and defended him. So it's very important to keep quiet for some time, and something really to be learned from Dr. Avilash Mondre sir. Dr. Mangesh Patel, he himself told he had worked at General Hospital. He had expressed his desire to be here physically almost 4 to 5 times. We did not invite him earlier actually, but it was so sort of coming from his heart that he wanted to be here. I gave him option, sir, it's from Dombivli to Talegaon. He said, no, I will drive. He came driving on his own and he shared his heart. I'm really grateful to Dr. Patel sir. Mangesh Patel is treasurer of HBI National. So Hospital Board of India is something again different. Ratika sir will know about it. So again, those who own the hospitals, they have to get attached to this HBI thing. It's very important. One important thing I share, we have a lot of different specialists. I'm a gynecologist, he's ophthalmologist, a physician, ENT specialist. In the beginning, we are general MBBS doctors. That COVID has shown. Workers have made a term, new term, despecialization. You must be always on the ground, rooted to the ground. Never forget that you are a doctor, I am a member, and a specialist. To not to get divided either by age or specialty or degree or designation or financial aspects. So we have to remain together, and IM is one body who is trying to keep all these people together, managing their own issues and helping each other. So it's very important to get attached to this social security scheme and this hospital board of India. Then we had beautiful talk given by Dr. Mubarak Khan sir. Again, as I told, I repeat, it was the longest talk, and he is all in one. Like he is already some 10 miles ahead of me. My thinking, my imagination. He is earning through 100 different sources. It's really a good thing. I wish him all the success, because if I want my guru to succeed, probably in these aspects of life, like let it be singing, let it be getting into another profession. Most important, remaining joyful. He doesn't really get stressed. I haven't seen him really getting stressed. Maybe there was a time he was getting stressed, but he has found way out of it. So very important. Very, very thankful to you on behalf of IMS, sir. Thank you very much, Mubarak Khan, sir. And he came here physically, though he is very much, involved into this webinar type of thing. But the feel of having person in front of you is very different. He immediately, in an emergency, accepted to be a panelist, though he wanted to leave. So thank you very much. We had very nice talk on modalities of imaging by Dr. Santosh Sabni, sir. He did CT scan or X-ray or whatever. So he made it very simple for all of us. We had a letter or poem received from Dr. Jumani sir. Again, those who know him like Amit and I know him, so he is a pure, blissful soul. He is absolutely fantastic human being, no egos, very senior, very joyful, very happy, and very, very much attached to Boge sir. He used to always, probably there won't be much difference between their ages, but Jumani sir always called Boge sir Dada. Whenever he used to come and meet us, he used to come and touch his feet. That Amit and me have noticed. Probably they are not classmates, they are not batchmates, they haven't worked for long, but their souls were connected. Once Jumani sir invited us for publication of his book at hands of Mr. Big B. Amitabh Bachchan. We couldn't make it to it, but I was dreaming that at least with Boge sir I also go and meet Amitabh Bachchan. It hasn't happened. So I'm really thankful to Dr. Jumani sir. Dr. Tambe sir gave his blessings and he is again, like the moment I have any problem anywhere from Baramati to Mumbai to Delhi, say we can talk to him and he will definitely try to guide. Dr. Vankit sir wanted to speak but he couldn't get connected. Definitely he was in some meeting. He is again one very strong force. I'm telling you, people like there are people who don't really interact with all the time, but they are there for you. Dr. Vankit sir is past IIM National President and his blessings were there with Boge sir and will be with us forever as long as we are there with IIM and also. If I have missed some speakers or something, I'm sorry. Then I'm thankful to Dr. Swati, Dr. Priya, they chaired this session. Again, it's very important for a woman to be away from home on Sunday, leaving their kids at home. So I'm grateful to you, Dr. Varsha and Dr. Vaishali, they are also sitting here constantly. Chaired the session as well and was sort of a support, and we did not get any phone call from home when conference will get over, so that was a good part of it, so I can continue for a longer time. Now I come to people who are actually doing this show. Like there are two things. Somebody builds a building and all the credit goes to the architect, then to the engineer, and nothing is left for the governee, the actual person who has put the bricks. All these people who are seen around me, they are standing around me, they are working with me, they are those important people. Most important is Mr. Rakesh Garud. Rakesh has been part of our team since Jericon. But if I don't thank him, probably God will not forgive me. So I'm really thankful to Rakesh for everything. Believe me, I'm just talking. Amit is guiding. Rakesh is doing. It's very simple. It's very, very, very clear. We all get everything done from him. And again, he does it absolutely selflessly. I request Amit to felicitate Rakesh. Again, this is one bond where he is not IMA worker, he is not doctor, he is my more like a friend. I'm just, sometimes I end up saying Dr. Rakesh. So he helped me in uploading the program to MMC, he helped me getting the mementos, trophies, all these LED, LCD, whatever, every technical, non-technical stuff, everything he does. So no words can actually do my job completely, but I'm really grateful. I'm doing this praising because I want him there for next TIMACON as well. So thank you very much in advance for next TIMACON as well. Then we have this photography team, Mr. Kashinath and his colleague. So they are recording, they are doing photography. It was relayed to more than 600 delegates globally. Few of my friends from United States had also logged in. Forget about India and Kanpur and Bangalore. So Telugu is gone global, though Mubarak Khan had taken it across the oceans earlier. On webinar, we are there globally. So, Kashinath, very much grateful to you for your recording and photography and your colleague. I'm thankful to this LCD man. They reached a bit late, but it's a nice picture. The state president was surprised. Such a small one, such a big LCD projector or something. So, thank you to you. Thank you for this sound system. those who are working with sound system, thanking the members of this Mawal Grand Hotel, Mr. Rakesh from Mawal Grand, Mr. Abhishek from Mawal Grand, Mr. Rahul from Mawal Grand, and all those grassroots workers who have helped us in that. They gave us good food, good hall. We used to come here at any time and inspect their hall and shout at them as usual as we do anywhere. So in a short notice, they have actually done all those things. And it's a small, good family function type of one. New invention, Mubarak Cancer, you can utilize this. And I'm also planning to small programs out here. So very important role they have played in our conference. Thankful, thanking our grand team per se, everyone for their support. Then there is a small, tall boy or man, I can say, sitting in the corner, Mr. Sachin or Dada Hari Kekan. He has been part of our team. See, there are something like I will generally say, if two mobiles can get connected through Wi-Fi, why can't two people get connected without a purpose, without a reason? A selfless connection. I had exactly same connection with my boss. We were not friends, we were not Guru Shishya, we were not relatives. One more thing, I never referred any patient to him, neither same was from his side. But we always had breakfast together and we missed each other at every meal or breakfast. So selfless connections are very important, and now also I don't really believe that in this conference I am not there, honestly speaking. I did not put much effort in this conference because I was only missing him, and thanks to everybody around me, they have done this for me. So Sachin has got into this. So generally things will be attractive to you. Rakesh is with us, Sachin is with us. There is Dr. Sachin Vitno, gynecologist, he was there. Dr. Nilesh Narkede, he was there. Last week there was sad demise in his family, but you are there and you could post vote of thanks. Great thing, courageous thing to do. Dr. Sudham Ketan, though he couldn't make it here, but he has also been working with us. And finally, if I don't thank my boss, my guru, my mentor, I don't know, there are no words actually. Whether I should say he spoiled me because I would have made more money practicing for more time, I could have given more time to my family, but he made me change and he entered something like a stranger and took me away to another planet, and now I am crazy about all those things, unstoppably crazy or mad about this. Working with INA or doing things or getting connected with people and friends, I have missed many people since my childhood. Everybody has, rather in family, in friends, and wherever. But for first time in my life, I understood that what is missing somebody and what is not having somebody in your life. So, as you pray to God and have belief in God, Sir had tremendous faith in medicine and tremendous faith in God as well. So, I believe to keep faith in these two as he did, and he always believed in helping people or not hurting people, rather knowingly. I have not really reached to his stage, but if I have hurt anybody here by any reason, I am extremely sorry. And once again, I thank late Dr. Boge sir. With that note, like I am thankful to Dr. Mrs. Usha Boge madam and Nilu and Rohit. They could come here, and it was as if, I haven't really got out of that fear or sorrow. I don't know when it will happen, but I hope it happens soon or it may happen never probably till I'm there. So again, thank you very much, Professor. And finally, I thank everyone. If there is nothing left for us for the day, I hope we all survived the COVID successfully. The panel itself was conquering COVID. We have conquered COVID. We have advanced physicians and surgeons and friends and family members. So with this, I am grateful to everyone who has contributed whatever small effort for TIMACON. I promise you, we will be coming up with TIMACON 2021. And as Sir has promised, definitely we will keep oration in name of Dr. Bhuveshwar. We will try to put it in the state IMA as well. And there are a few more things which we will discuss on our local meetings probably. And I really need your guidance and help. Satika sir, once again, very thankful to you to be here, Dr. Sir, and everyone. So thank you, and with this I say Jai IMA, Jai Maharashtra, Jai Hind. Go home safely, take care. Oh, yeah. When you get emotional, you forget things. Okay, but it's nice to be emotional and nice to forget things also. So, my boss has reminded me of thanking DigiShield. Now, this DigiShield is something very funny. I don't know how many of you have got it, but they are a company into all this webinar thing and lot many other things related to medical science and otherwise. So, I should thank Dr. Samir Chandratre, who is president IIM Nashik, happens to be brother of my friend. So they had conducted their Hospicon some 2 months or 1 month ago, and it was fantastic. I had registered, and then I got idea this is possible. So he shared number of Mr. Dipen Mehta. So I'm very much thankful to Mr. Dipen Mehta from DigiShield and the executive man, the one who had flashed the DigiShields or the mementos, Mr. Aditya. So thank you very much, Mr. Aditya. I hope you are listening to me.
Yes, sir. You're welcome, sir.
Thank you very much, and thanks a lot to your whole team. We are hoping to be with you more frequently, regularly for all our meetings and conferences, and wish you all the success in whatever future plans you have along with the medical science team. So thank you very much, digital team. Finally, they say भगवान है मगर उसको पुजारी नहीं है, पुजारी है मगर भक्त नहीं है. तो I ultimately thank all our audience across the globe, everybody, those who are logged in from today morning 9 o'clock till today like this time 5 o'clock, and they have been observing us. I'm really members, all the IIM members, all the MBBS doctors who have registered. Friends, we have more than 600 registrations. We are a branch of 60. Talegaon is a branch of more than 60 members. We have 600 registrations. And it's something unbelievable. So that's really tribute to our boss, and we are happy that you all contributed to our success of this conference. So once again, thank you everyone. I take responsibility of any failure, any inconvenience, any regret anybody had personally, and I definitely give credit of all this success to my mentor, Dr. Bhuvesar, and my colleague, Dr. Amita, and Dr. Anish, and Dr. Yuvraj, and Dr. Sudha, and Dr. Narkade. So thank you everyone. Thanks a lot.
With this, the IMA conference has concluded. Please join us for the evening tea. Have tea and have a chat. Thank you very much.